It's important to know how your curing light works and to be absolutely certain that you are 100% polymerizing that material before moving on to the next step. It takes about 20,000 megawatts, milliwatts, excuse me, centimeters squared to cure a composite resin. So if our curing light kicks out about 1,000, then how long do you think it takes to reach that level of energy? It takes about 20 seconds, right? 20 times 1,000 is 20,000. So when I was in dental school, we had these lights, and we were always told that we had to cure our composite for 40 seconds. And 40 seconds is an eternity in the dental chair, right? So, but the reality is, in order to reach that 20,000, you have to know what the output of your light is. Now, this number, this 20,000 number, can vary depending on the type of composite and shade. For instance, it takes much more energy to cure an A4 shade composite than it does a B1. So that's a good thing to know. The other thing to know is some of these bulk fill materials take maybe a little bit less time. All right, so we're using the low strength materials as a dentin replacement. And then I personally like to build a little bit of primary anatomy into my composite restorations as I place them. And I'll show you what I mean by this here in a minute. And I prefer a hybrid composite for this rather than the bulk fill materials. The reason for that is this. The reason why the bulk fill materials are able to be polymerized to 4 millimeters is because they're relatively translucent. So they have kind of a grayish appearance. Now, in the posterior, that's not going to be a big deal in most cases. But as I said, I work in a cosmetic practice, and there are patients who will sometimes call me out for using a material that doesn't blend very well with the two structures. So in order to be on the safe side, I use my tetric prime as the hybrid composite, as the capping material, rather than the high strength bulk fill material. And this tooth has already been bonded, so we are ready to restore. And so the first thing that I'm going to do is, just like I told you, I'm going to use that power flow, that bulk fill flowable, as a dentin replacement. Okay, and I'm going to build that up, including into the interproximals, build that up to the DEJ. Now, in the interproximals, I am basically just going to line the floor of my box, okay? And the reason that I do that is because any small gaps between the matrix band and the tooth, I want to make sure I seal those. And it's much easier if you have a little that sneaks past your band. It's much easier to smooth that off, to trim that overhang if it's flowable than if it's condensable. So once we cure that flowable in those proximal areas, we don't have to worry about our condensable composite creating an overhang that is now much more difficult to trim. So using that power flow to replace the dentin. And then what I like to do is I like to build the interproximals first. When you have two rings like this, it's hard to get access. I mean, you're having to, this is a maxillary tooth, so you're having to position your mirror. You're trying to see in there. You've got these rings blocking the way. Once again, we were talking about curing earlier. You got to get a curing light in there. There's a lot going on. So I like to restore the interproximals first. And I do that with, once again, I prefer my tetric prime, my hybrid composite, but you can use a condensable bulk fill as well for this. So I cure those, or I place and restore those first, and then I will cure those. Next, what I'm going to do is I'm going to restore just either the buccal or the palatal first. And the reason for this is because I like to build anatomy in as I'm placing my composite. You might not think that this is time well spent, right, to build anatomy in while you're placing, but the reality is you actually, if at least in my hands, save time in the finishing stages, building just some rudimentary anatomy in as I'm doing that. I don't want to go and grind all that in after the fact. There's some data out there that suggests that you can create enamel fractures by over finishing, and it's those white lines that can show up on the edges of your composite that can stain and allow bacterial proliferation and entry over time. So we want to make sure we're not over finishing our composite. So just add a little bit of kind of rudimentary anatomy in, and this is what it looks like once it's all said and done. And of course, oftentimes we lose some of that anatomy when we check the occlusion and things like that, but that's okay because we're more likely to have less occlusal issues and less occlusal adjustments if we're building that anatomy in from the get-go. So before and after, once again, I don't know about you, not my favorite procedure, but our patients expect us to do really good dentistry on them, and so we have to find a way to do that. So we get a nice, really nice, robust contact with that sectional matrix system, and of course with that rubber dam. I like the rubber dam. I'm kind of old school that way, and we get really good isolation as well.